All right, so why don't we get started? I'm Ben Ristau. I'm a urologist and urologic oncologist at the University of Connecticut, also known as UConn. One of our residents, Dr. Wagner, is here also. She'll be collating some questions that come up. Feel free to enter them in the Q&A section. I'll try to address as many of them as I can towards the end of the talk. I'm going to talk a little bit about treatment for clinically localized prostate cancer. That can be covered, or would need much more than an hour to get it covered all in one, but I thought I'd look at some of the level 1 evidence and really take an examination of that. So I have no relevant financial disclosures. I am a urologic oncologist. So as far as objectives, I'd like to review the current prostate cancer risk stratification and guideline recommendations, briefly discuss some of the major screening trials, and really the goal there is to assess what the cancer risk is like in the population. We'll kind of take a deep dive into the 3 major prostate cancer treatment trials that exist. If we have some time, and if not, I'll include the slides when I post them online, but a short foray into some of the radiation trials with a focus on the duration of ADT based on risk and where that comes from. So the 30,000-foot view, if we start from there, is the prostate cancer epidemiology, risk stratification, and what the guidelines actually recommend that we do. So most of you know these stats, but there's approximately 191,000 estimated cases in 2020 in the United States. The median age of diagnosis is 66 years, and this translates into about 33,000 estimated deaths at a median age of 80 years. Approximately 1 in 9 men will be diagnosed in their lifetime. That's a relatively high percentage, but the number that actually die from prostate cancer is relatively small. And so it is common, but almost 97% of men die from something other than prostate cancer. So I think it's helpful to keep that perspective as we kind of dive into the weeds with some of these trials. When we talk about risk stratification, there are many different ways to stratify risk. They're all quite similar, and I'll kind of go through them one by one. And management choices are based on both risk or biology, as well as life expectancy. And there's a pretty famous quote from Blake Cady in the 1988 presidential address to the Society of Surgical Oncology, where he referred to tumor biology as the king and case selection as the queen when it comes to outcomes. And I think it speaks to risk and life expectancy with regard to prostate cancer. The original risk stratification that I'm aware of was the D'Amico risk stratification. Low-risk patients were defined as clinical stage T1C to T2A with a PSA of less than 10 and a Gleason score of 6, which is now thought of as grade group 1. Intermediate risk disease, it was clinical stage 2B, PSA between 10 and 20, and a Gleason score of 7, which is now grade groups 2 and 3. And high-risk patients were anything higher than T2C, PSA greater than 20, or a Gleason score of 8 to 10, which is grade groups 4 and 5. The AUA has added a very low-risk stratification to this, and that is essentially when less than a third of the total biopsy cores are involved, less than 50% of any one biopsy core is involved, and a PSA density of less than 0.15 nanograms per milliliter per cc. Intermediate risk is stratified into favorable and unfavorable, and you can see there what those are. And high risk is T3, PSA greater than 20, or grade group 4 to 5. Similarly, the NCCN has a risk stratification, very low risk and low risk. Intermediate risk is, again, divided into favorable and unfavorable, and this is actually quite similar to what the AUA recommends as well. The intermediate risk factors are either T2B or T2C disease, or grade group 2 or 3 disease, or PSA 10 to 20. They actually have a very high risk category, which is either clinical T3B or T4, a primary Gleason pattern of 5, or more than 4 biopsy cores with either grade group 4 or 5 prostate cancer. And I would be remiss in a UCSF lecture series not to mention the Kappa risk stratification score. This is a score that's derived by assigning a point system to PSA, Gleason score, T-stage, percent of positive biopsies, and age. And the sum of that score can be divided into low, intermediate, or high risk. And Dr. Cooperberg has done a lot of work validating the Kappa risk stratification. So that's risk. How about life expectancy? Well, there are a number of life expectancy estimation tools. Social Security Administration tables are one. The WHO has some life tables. Memorial Sloan Kettering has a male life expectancy tool, and UCSF has an e-prognosis tool for estimating life expectancy. There is also an NCCN guideline for older adult oncology, and they reprinted a graph looking at life expectancy from a JAMA paper in 2014. And you can see that you don't have to get to a certain age group before our life expectancy of quote unquote 10 years that we use for prostate cancer starts to hit that point. So by age 75, most men, 50% essentially, have less than a 10-year life expectancy. So that puts that in perspective. And our guidelines, most of them that we have, are stratified by risk. And I'm going to focus on the NCCN guidelines, but they're all quite similar. So for very low risk and low risk, this is most patients in this category are going to be recommended to have active surveillance. I'm not going to get into a lot of details on that because this is the first spoiler alert. There is a COVID online lecture series with Peter Carroll on May 27th from 9 to 10. And that is, he'll go into great detail, and he does a fantastic talk on active surveillance. So he'll cover that in this lecture series. For intermediate risk, when we look at favorable intermediate risk, if the life expectancy is greater than 10 years, active surveillance can be considered. External beam radiation therapy or brachytherapy, as well as radical prostatectomy with lymph node dissection. If the life expectancy is less than 10 years, observation is preferred, and external beam radiation therapy or brachytherapy can be considered. With unfavorable risk, all treatment options are available: radical prostatectomy, radiation with hormone therapy, usually talking about 4 to 6 months, or radiation with brachytherapy. And again, if the life expectancy is less than 10 years, generally observation is preferred. For high and very high risk, life expectancy greater than 5 years or symptomatic, external beam radiation with hormone therapy anywhere from 2 years. Docetaxel can actually be considered for the very high risk population. Radical prostatectomy and pelvic lymph node dissection also an option here. This is the second spoiler alert. There is another COVID lecture series coming in. Ken Nepple from Iowa is going to talk about high risk metastatic and biochemical recurrence on May 9th. So tune in. So I won't focus a lot on the high and very high risk populations because that is also going to be discussed later on. So screening trials, this is coming down a little bit in the airplane from 30,000 feet to about a 10,000 foot view to kind of get a little better eye of the landscape. So why would I take a brief aside to talk about prostate cancer screening trials? And the reason is that it's critical to understanding and interpreting data from prostate cancer treatment trials because the screening trials identify the prevalence of risk categories in the population. So it gives you a sense of what's actually out there. So how common are low, intermediate, and high-risk prostate cancers in the male population? Most of you have heard about ERSPC screening trial and the PLCO trial. The CAP trial is a little bit less well known, but it actually served as the feeding for the PROTECT trial, which we'll talk about a little bit later. This was done in the UK. It was a cluster randomized trial of PSA screening. It's called the CAP trial. It was a little bit different because it was a single PSA screening test. It was not multiple screening tests. And the intervention group, about 75,000 of them attended this PSA clinic. About 6% had a prostate cancer diagnosis, so that tells you how common prostate cancer is in the population. A handful of them actually did not attend a PSA clinic, and prostate cancer was ultimately diagnosed in 3% of those patients. The control group was not offered PSA screening, and prostate cancer diagnosis was about 3 to 4%. So here's a chart, a table that compares the incidence of different Gleason grades among the 3 screening trials. You can see that the incidences are higher in ERS-PST and PLCO because they received more PSA tests, and so more prostate cancers were identified. But what you can see here is that for all of the trials, essentially, the most common grades in the population are Gleason grades 6 and 7, and also low clinical stage, so T1 or T2. The vast majority of screening identifies essentially low and intermediate risk prostate cancers. And I made this graph to show it in a picture because I think it's a little bit easier to see. This is Gleason grade groupings. The blue is Gleason 6, the orange is Gleason 7, and the red is Gleason 8 to 10. And you can see that high-risk cancers are relatively rare in the population when you're detecting things by screening. Similarly, staging, clinical stage 1 and 2, when you're detecting things by screening, is much more common than clinical stage 3 and 4. And when you screen more often, like in ERS-PC and PLCO, you find even more of these lower and intermediate risk cancers. If you don't screen as much, you find some higher risk cancers because many of them start to present clinically. And so I hope that these are non-controversial conclusions from the 3 major prostate cancer screening trials that we have so far, are that most prostate cancers in the population are either low or intermediate risk, and that high-risk prostate cancers are relatively rare. And this is actually really good news for patients because most low-grade and intermediate-grade tumors have a long natural history. Peter Albertson showed us this in his JAMA paper from 2005. Men who are older than 70 with low and intermediate grade tumors are at least 1.5 times more likely to die from something other than prostate cancer. And I chose this particular graph because this is the Gleason 7 prostate cancer in the age 70 to 74 age group. And it shows you that after 20 years, only about 40% of them are dying from prostate cancer, and 60% of them are dying from something else, and almost all of them have died together. But it does make it really challenging to decide who benefits from treatment, because if we're including everyone in the treatment trials, then even the people who aren't necessarily needing treatment are getting that intervention. And so it's a little bit difficult to tease out who really benefits. And so the brief aside is that since most screen-detected prostate cancers are low and intermediate risk tumors with relatively long natural histories, it may explain why the survival differences between treatment and observation are not as robust as we might hope, because these are the entry criteria of people that come into these trials. So now we're gonna get into the weeds here and take a deep dive into some of these surgical trials for radical prostatectomy, treatment trials with radiation, and also observation. And so there are basically 3 prostate cancer treatment randomized control trials that have been reported. The Scandinavian Prostate Cancer Group 4, SPCG4, Pivot, and Protect. Those are the 3 major trials that all urologists really should know. So I'll start with SPCG4 since that was the first. This was 695 men that were recruited from the late 80s to the late 90s. After 1994, screen detector cancers were allowed, and this coincides with the advent of PSA screening. Most prostate cancers were detected due to symptoms. That was about 40%. And only 5% of men in this trial were detected based on screening. So it tells you, where in the disease process these patients entered into the trial. The watchful waiting group received no immediate treatment. The radical prostatectomy group started with a node dissection. If the nodes were negative, the prostatectomy was completed, but if the nodes were positive, the prostatectomy was omitted. Most people aren't doing that now, but that was a very common thing to be done in the 80s and 90s. The follow-up was every 6 months for 2 years and then annually. It included a DRE and a PSA, and the bone scan and the CT scan were done annually. There were no routine adjuvant therapies given. Local progression in the watchful waiting group was treated with a TURP. Local progression in the radical prostatectomy group was treated with either orchidectomy or gonadotropin-releasing hormone agonists. Systemic metastasis were treated with orchidectomy or GnRH agonists. The primary outcome was disease-specific mortality. Secondary outcomes were metastasis-free survival, risk of local tumor progression, and overall survival. The age of patients was 65. The mean PSAs were high, probably higher than what we see now. So in the watchful waiting group, it was 12.3, and in the radical prostatectomy group, it was 13.5. Only about 10% of patients were T1C, and 3/4 of them were T2. 60% of the population was Gleason 6, 25% Gleason 7, and only 5% Gleason 8 to 10. And here's a chart that I made comparing the different reports that came out of SPCG4. The median follow-up is across the first row of the chart. It started with 6.2 years in 2002 and progressed to 13.4 years in 2014, and then 23.6 years in 2018. And you can see as you move from the left to the right of this table, essentially every outcome starts to favor radical prostatectomy the longer the follow-up is for. So for all-cause mortality, ultimately, watchful waiting, 83% of people had passed away by a median follow-up of 23 years, whereas it was 71% in the radical prostatectomy arm. For prostate cancer mortality, it was 31% in the watchful waiting arm and 20% in the radical prostatectomy arm. There were more metastases noted in the watchful waiting arm compared to the radical prostatectomy arm. Progression locally was much more common in the watchful waiting group. Use of androgen deprivation therapies, more common in watchful waiting, and use of palliative radiation was about the same. In the 2014 update, the number needed to treat to prevent 1 death decreased from 20 at 10 years to 8 at 18 years. And in men less than age 65, it decreased from 8 to 4. In the 2018 update, the stat was that the median years of life gained after 23 years of follow-up was about 3 years, and the absolute overall survival benefit for radical prostatectomy was 12% at 23 years. When you look at risk stratification in the SPCG4 trial, the greatest benefit was found in low and intermediate risk patients. Interestingly, in the high-risk population, now granted that there were few patients, but none of the outcomes were significant except for the use of androgen deprivation therapy. So there was really no difference in mortality among high-risk patients, and the benefit was seen in low and intermediate risk groups. Well, what about quality of life? You can't have a prostatectomy discussion about the benefits without talking about the drawbacks. So at a median of 12.2 years, there were 400 SPCG survivors compared to the control group of 281 men. Remarkably, at 12 years of follow-up, an 87 to 88% response rate was achieved. And you can see that the quality of life amongst the people in the study was slightly worse than a control group of men who did not have prostate cancer, but was pretty equivalent across the two groups. Anxiety was a little bit higher in the trial groups compared to a control. Erectile dysfunction was comparable in the watchful waiting and radical prostatectomy arms, although it seemed to bother the radical prostatectomy folks more. Urinary incontinence was clearly higher in the radical prostatectomy group as compared to the watchful waiting group. Obstructive symptoms like weak stream or nocturia favored radical prostatectomy, and the watchful waiting group had worse obstructive symptoms. So what can we conclude about SPCG4? Men who live longer derive a greater benefit from radical prostatectomy. It persists in low and intermediate risk tumors, but not for high risk tumors, at least in this study. Radical prostatectomy results in less local recurrence. Men who undergo radical prostatectomy are much less likely to require palliative treatments compared to watchful waiting. The cost of these benefits, though, is reduced quality of life with regard to erectile dysfunction and urinary incontinence. So moving on to PIVOT, PIVOT being the second randomized treatment trial that we have. This was from the mid-90s to the early 2000s. So this is when PSA was starting to be introduced into the prostate cancer world. 731 total men, 364 in the radical prostatectomy arm and 367 in the watchful waiting arm. Interestingly, there were 5,000 eligible patients, and almost more than 80% of them declined to be randomized. The inclusion criteria were that men had to be less than 75 years old, their PSA had to be less than 50, they needed a negative bone scan, and at least a 10-year life expectancy. The follow-up was every 6 months with bone scans at 5, 10, 15 years, and at the end of the study. The primary endpoint was all-cause mortality. Secondary endpoints, prostate cancer mortality, PSA recurrence-free, metastasis-free, and local progression-free survival. The original power calculations were to achieve a 90% power to detect a 15% relative reduction, which is the same as a 5% absolute reduction, at a median survival of 12 years required 2,000 patients. Now, obviously, they didn't get there since they only had 731 men in the trial. So because of these recruitment difficulties, they went back and did a second power calculation, reduced their power to 85%, and increased the reduction or the difference they wanted to see between the two groups to a 25% relative reduction, which was a 15% absolute reduction at 8 to 15 years of follow-up. This required 740 patients, which is about where they ended up. The mean age of the cohort was 67 years, so a little bit older than SPCG4. About 65% of the population was older than 65 years old. The mean PSA was 10.2. About half of the population had a PSA less than 10, and about 3/4 had a PSA less than 20. In 75% of the population, a PSA elevation was the reason for a biopsy. So this is already much different and a much earlier time course in the disease than SPCG4 was. 50% of them were T1C, about 40% had palpable tumors. About 3/4 were Gleason 6 or lower, 20% Gleason 7, and 5 to 6% Gleason 8 to 10. So many of you know that the primary outcomes, this was a negative trial. There was no difference in all-cause deaths or prostate cancer mortality reported at a median follow-up of either 10 or 12, of up to 12.8 years. There was, however, a difference in bone metastasis between the groups. So higher rate of bone metastasis in the watchful waiting group, as well as progression and treatment for progression in those groups. By risk category, there was another interesting trend. So all-cause deaths favored radical prostatectomy, but only in the intermediate risk group. What about the quality of life? So ED requiring treatment, as you might imagine, was higher in the radical prostatectomy group. It was about 15% compared to 5% in the watchful waiting group. Urinary incontinence required treatment, about 17% in the radical prostatectomy group compared to 4% in the watchful waiting group. Overall, however, there were no major differences in physical, mental, or worry about health between the two groups. So what can we conclude? Men with low-grade disease and less than 12 years of life expectancy do not benefit from prostatectomy. It definitely supports active surveillance in these men. The subgroup analyses were underpowered, as was the whole study, but there may be a signal of benefit in the intermediate risk group. Treatment for progression in the watchful waiting group was nearly double, sorry, that's a typo, that of the radical prostatectomy group. And men who undergo prostatectomy report worse sexual and urinary function compared to watchful waiting, but this did not seem to impact the overall physical or mental health, at least in this study. So the last trial is the PROTECT trial. So this included a little over 1,600 men that were recruited from the CAP trial, that prior discussed screening trial. 545 were in the active monitoring arm, 553 were in the radical prostatectomy arm, and 545 were in the radiation therapy arm. Now, interestingly, this is the only trial, at least that I'm aware of, that is comparing radical prostatectomy to radiation therapy in this setting. So the active monitoring group, a little bit different than what we traditionally think of as active surveillance. So these patients received a PSA every 3 months in the first year, every 6 to 12 months after. A rise of 50% in the PSA over 12 months triggered a repeat PSA about 6 weeks later. And if elevated, biopsy versus treatment was discussed. Radiation therapy was given with androgen deprivation therapy 3 to 6 months prior to radiation. 74 gray was given in 37 fractions. This is conventional fractionation. A nadir of the PSA, the lowest point, +2, that's the Phoenix criteria that was used to determine recurrence. The radical prostatectomy group was predominantly an open radical prostatectomy. A pelvic lymph node dissection was done if the PSA was greater than 10 or if Gleason 7 or higher. A PSA was done every 3 months in year 1, every 6 months in year 2, and then annually thereafter. Adjuvant therapy was discussed for either a positive margin or extraprostatic extension on the prostatectomy specimen. Salvage was discussed, salvage therapy was discussed for a PSA of greater than 0.2. The primary outcome was prostate cancer mortality at 10 years. Secondary outcomes were overall mortality, incidence of metastasis, clinical progression, treatment complications, including patient-reported quality of life. Clinical progression was defined as any of these, so metastasis, development of T3 or T4 clinical disease, long-term use of androgen deprivation therapy, ureteric obstruction, rectal fistula, need for urethral catheter secondary to tumor. So the median age was 62. Median PSA was 4.6. So you can already see that this is a more modern trial probably to what we see now. A large lead time associated with the diagnosis when you're screening. 77 of the patients had 6 disease, and 76 were diagnosed only on screening and did not have palpable disease. 291 of the 545 patients who were assigned to active monitoring ultimately received treatment during the course study, and the median follow-up was 10 years. So what did we find? Only about 1% of people over the course of 10 years died from prostate cancer. This is very different from some of the other trials, and the reason is most of these prostate cancers were detected based on screening, and so we're at an earlier time point in the course of the disease. There was no difference in all-cause mortality between active monitoring, radical prostatectomy, or radiation therapy. It was about 10% in all groups. There was a notable difference in clinical progression and metastatic disease. So about 20% of people in the active monitoring arm experienced clinical progression, compared to about 8% in the radical prostatectomy and radiation therapy arms. and more patients developed metastatic disease in the active monitoring arm, about 6% compared to about 2 to 3% in the treatment arms. So what about quality of life? The study questionnaires were completed at baseline, 6 months, and annually thereafter. The response rates for the majority of measures were greater than 85%, even at 6 years. I'm in awe of some of these trials that are done in Europe, that they're able to get such profound response rates and follow up with these patients. It's pretty remarkable. So what about the quality of life? Urinary incontinence for radical prostatectomy was worse at 6 months. That's the first graph up on the right-hand side. So you see a precipitous drop, and improved, but remained both worse than active monitoring and radiation therapy at all time points. After 2 years, incontinence was worse, but its actual impact on quality of life when you asked that question to the patients was similar to the other groups. ED was worse in both treatment groups and persisted, and relative to radiation therapy, the men in the radical prostatectomy group experienced worse erectile dysfunction compared to radiation therapy. And at 6 months after radiation therapy, bowel and irritative voiding symptoms were worse compared to prostatectomy and active monitoring. The urinary symptoms returned to baseline, but the bowel symptoms did not. So the conclusions from PROTECT are that after about 10 years, there was no difference in death from prostate cancer from screen-detected prostate cancer, which affirms active surveillance for low-risk prostate cancers, which is most of what you find by screening if you consider the prior screening trials. Erectile function suffers in men who undergo radical prostatectomy and radiation therapy with curative intent. There was more clinical progression in the active monitoring group, although 80% did not progress at 10 years. So 20% did, but 80% did not. The risk stratification outcomes are not yet available. It'll be interesting to see if those analyses are powered well enough to be able to come up with some conclusions about the intermediate and high risk groups. So we've gone from sort of the 30,000-foot view of what's out there to the screening trials a little bit closer, get a little bit more detail, and all the way into the weeds with these 3 trials. And there are a few nuances that I thought I'd try to get across. When we screen for prostate cancer, we find mostly low and intermediate risk prostate cancers because that is what is in the population. The subgroup analyses for unfavorable, intermediate, and high-risk cancers in these studies may not be adequately powered, but these are the exact groups in which we want to understand the treatment benefit. And trials that recruited patients based on screening will take longer to see a potential benefit to the treatment due to a lead time bias. So the question, I think, that is very hard to both communicate and answer is, would you trade your current quality of life for possible quantity of life 15 plus years from now? And I mean, these are my answers. I would say at age 55, probably yes. At age 70, I think if you're a healthy person, you're going to have a pretty long life expectancy at age 70. At age 65, maybe. I think it depends on how healthy you are. At age 75, you're trading current quality of life for quantity of life years at age 90. Maybe not, but this is my 94-year-old grandfather with my son. He's 94. I would argue that the last 3 to 4 years of his life have been incredibly valuable as he's seen Lars grow up and as he's seen my brother's kids and his other grandkids' children live. So you obviously can't know that you're going to live to age 94 when you're 65, but it's something that you need to help communicate to patients that there are quality of life years even beyond age 90 that are possible. And then, can more data help us answer these questions, or are the answers a little bit more philosophical in nature? So, when you talk about population-focused versus individual-focused medical practice, when you look at a big view of the population, certainly PSA screening may not be of value, but when you're sitting there talking to a patient one-on-one in your clinic, that person either has an aggressive prostate cancer or they don't. There's no real in between. So no amount of data is going to help you answer that question. It's something that you have to work on and help communicate patients. And then within patients themselves, are they risk averse or risk tolerant? Now, there are some people who don't want to take any risk that they may die from prostate cancer. And there are others who would look at risk in a different way and say, that doesn't sound so bad. And I was reminded of this when I was watching, I don't know how many of you have seen the Michael Jordan documentary, The Last Dance. But going into his second year, he fractured his foot and he was unable to play the game he loved. And he ultimately was really pushing to get back out on the court. And he asked the doctors what his risk was of re-injuring himself. And they said it was about a 90% chance he'd be completely fine and about 10% chance that he would break his ankle and make it worse. And so the way that it was put by the owner was that if you had a headache and you had an opportunity to take a pill to get rid of it, and 9 of the pills cured the headache and 1 of the pills killed you, would you do it? And his response was, that depends on how expletive bad the headache is, right? So it gives you a sense of, you have to be able to communicate both the tumor risk, the biology of the tumor to the patient, as well as gauge their life expectancy and their risk tolerance, because everyone's going to have a different answer to that question. So I'm happy to take some questions on that portion of the talk. I have like 3 or 4 more slides to go that I have in queue to talk a little bit about radiation and androgen deprivation therapy. But before we get there, that was a lot of me talking, so I'm happy to address any questions that you might have.
Thank you, Dr. Ristau, for the excellent talk. And if everyone can also fill out the survey, that would be great. If you've submitted your question into the chat, if you can copy and paste it into the Q&A, that way it'll save it for those who want to look at those answers later. So our first question is regarding the natural history of patients who are relatively healthy and have organ-confined grade group 2 and grade group 3 prostate cancer. What would you tell them about the natural history of their disease?
So I think grade group 2 and grade group 3 are different. If they're young and relatively healthy, and have grade group 3, that's a primary pattern, Gleason pattern 4. I think most of those patients would benefit from treatment. Grade group 2 is I think the frontier of surveillance, and where a lot of people have a little bit of difficulty answering the question. We know from Lori Klotz's data from Toronto that patients with Gleason 7 3+4 disease do worse in terms of metastasis-free survival compared to grade group 1 tumors. But when I have the conversation with patients about grade group 2 cancer who are healthy and ultimately probably will choose to have treatment, I sort of couch it in a when is it convenient for you to have surgery kind of discussion. I've had a number of patients who, either they're going on vacation over the summer or they have a wedding in a few months, and I think the data would tell us that waiting 3 to 6 months or even longer for some of these patients and doing sort of an initial active surveillance approach isn't going to really compromise their oncologic risk. So in that group of patients, I think there's a little bit of leeway. In the grade group 3 patients, that that starts to make me a little bit more nervous that they have a higher oncologic risk.
Thank you. Our second question is about patients who choose watchful waiting. What do you tell them about their risk of no treatment? And specifically, do you describe what dying of prostate cancer is like?
So that's a good question. I mean, I think it depends on the patient. If it's a young patient who you get the sense is just scared or afraid of a treatment option, then I think talking to them in real terms about some of the things that could happen if prostate cancer is left unchecked may help them make a more informed decision. I think if you're not talking to patients about, either locally advanced disease and urinary retention or bone pain as a result of advanced prostate cancer, then you're also not giving them the information on the longer risk end of the spectrum to make the decision. I think you also, in patients who are just generally averse to treatment for whatever their reason is, I think it's also important to provide them that sort of information. So these are healthy patients. In less healthy patients who are either electing watchful waiting, but have less than a 10-year life expectancy, I'm usually not talking to those patients about it because I also, I kind of don't want to scare them into more treatment than probably they need based on the available data. So those are the two differences. So I think if you were to stratify it, I would say in the patients that really are healthy and probably should have treatment if cure is their goal, I think you're a little bit remiss to not discuss what advanced prostate cancer looks like. But in the patients who probably aren't going to benefit from treatment, I don't know that you have to go into a lot of detail about that, but that's my personal opinion.
Thank you. From Doug Ridier, there seems to be a transition in management from prostate cancer to focus on higher risk patients, but there doesn't seem to be any level 1 evidence that supports local treatment of high risk patients. What evidence is there to support treatment like radical prostatectomy in a high risk patient?
So Ken Nepple is going to talk a little bit about that on May 9th, I believe. But there is evidence from Stampede and others on Latitude to look at radiation therapy in combination with systemic therapy and supporting a survival benefit. There has not been any direct evidence, at least level 1 evidence that I'm aware of, that radical prostatectomy is of direct benefit in the high-risk population. Certainly, I think there is evidence, and you can see it in these trials, that a radical prostatectomy helps with local control and reduces the risk of local progression and symptoms. And that I would include that in the high-risk population. But another thing I noticed as I was carefully going through these trials is that many of the treatments that we're applying that seem to be commonly applied for high-risk prostate cancer now, upfront radical prostatectomy followed by radiation with hormone therapy, was not the standard in these trials. So I think the verdict is still out in terms of high-risk prostate cancer and how much treatment of the primary tumor will help. I think also, you're starting to see people exploring treatment of the primary tumor in low-volume metastatic disease. I know Brian Chapin is leading a SWOG trial looking at that. So these are all interesting questions that I don't know that we have the answer to, but it's a good question.
And then finally, any comment on racial disparities or racial differences in prostate cancer outcomes or treatment, specifically for African American patients, and how that might relate to patients who have a strong family history?
Yeah, I mean, I think we all know that the outcomes among the African American and Caribbean American population are not as good as the Caucasian population. Both SPCG4 and PROTECT had a predominantly Caucasian population. Interestingly, PIVOT had about a 25% African American population in that study. And so I don't think there is level 1 data to really answer that question adequately. But we do know, obviously, that people with a family history and African American men have higher risk and poorer outcomes compared to Caucasian men.
Thank you. I think that's it for our audience questions.
Great. I'll pop through real quick since we have a little bit of extra time. I just have 4 quick slides on where, because you hear about androgen deprivation therapy and whether you give 4 to 6 months or whether you give 2 to 3 years. And most people, in my experience, aren't completely entirely sure where these data come from. This is the sort of the reference slide of where it comes from. But the first trial is RTOG 9408. These were primarily intermediate risk patients. They were clinical stage T1 to T2B with a PSA less than 20. It was a huge study. 992 patients got radiation alone. 987 patients got radiation with 4 months of androgen deprivation therapy. About 60% Gleason 6, 30% Gleason 7, and 10% Gleason 8 to 10. Low risk was 35%, and intermediate risk was 55%, only 10% in the high risk category. The median follow-up in this trial was 9.1 years. Overall survival was 57% in the radiation group, 62% in the radiation with androgen deprivation therapy group. Disease-specific survival, 8% in the RT, sorry, this is mortality, 8% and 4% in the RT plus ADT. PSA recurrence-free survival, 59% in the RT group, 74% in the RT plus ADT group. And metastasis-free survival also was not significant. So in this RTOG 9408 trial, overall survival, disease-specific survival, as well as PSA recurrence-free survival all favored the addition of 4 months of androgen deprivation therapy. There was another trial out of Boston, D'Amico and colleagues. These were patients with clinical stage T1 to T2B with 1 unfavorable risk factor, PSA greater than 10, but less than 40, Gleason 7 to 10, or EPE or SVI on the MRI. 104 patients had radiation alone. 102 patients had 6 months of androgen deprivation therapy. Most of these patients, about 75 to 80%, were Gleason 6 or 7. Only about 15% had Gleason 8 to 10 disease. The median follow-up was 7.6 years, and both overall survival and disease-specific survival favored the radiation with ADT group. So in summary, 4 to 6 months of ADT is recommended in addition to RT for the intermediate risk population. For high risk, there was an EORTC study that was done that was a high risk but not metastatic population. They received either radiation alone, 198 patients, or radiation with 3 years of androgen deprivation therapy. That was 203 patients. Most patients were Gleason 7 to 10. Most patients had T3 or T4 disease, 80 to 90%, and the PSA was greater than 20 in over half. The median follow-up was 5.5 years, and the overall survival, disease-specific survival, PSA recurrence-free survival, and metastasis-free survival all favored the addition of androgen deprivation therapy. Another RTOG study, this one's 9202. These are patients with T2 to T4 disease. One arm was radiation with short-term androgen deprivation therapy, so 3 to 4 months of ADT. That was 763 patients. The other was radiation with 2 years of ADT, 758 patients. More than half of these patients had Gleason 7 to 10 disease. About half of them had T3 to T4 primary tumors, and the PSA was higher than 30 in a third. Median follow-up was 11.3 years. The overall survival was not significantly different, but disease-specific survival, PSA recurrence-free survival, and metastasis-free survival all favored the long-term 2-year androgen deprivation. So this is the summary here. 2 to 3 years of ADT is recommended, in addition to radiation therapy for high-risk prostate cancers. So if you're wondering where those recommendations come from, that's where they come from. I'm happy to take any other questions before we finish up, but otherwise I'll plan to sign off. Thank you very much for coming, and I'll go back to the slide with the survey on it.
If anyone has any other questions, you can submit in the Q&A, and if we don't get to them now, they will be posted online. People have posted.
Great. Thanks very much, everybody, for coming, and I hope you're all well.